Welcome. Today, we're diving into the key resistance patterns of Staphylococcus aureus, a major cause of infections in healthcare and the community. Understanding these patterns, MSSA, MRSA, VRSA, and LRSA, is crucial for both clinicians and students. We'll break down what each abbreviation means, how resistance develops, and the main treatment strategies. Let's start by setting the stage. S. aureus is a versatile bacterium, and its ability to develop resistance makes it a persistent challenge in medicine. Ready to unravel these important concepts? Let's begin with the basics. First up is MSSA, which stands for methicillin-sensitive Staphylococcus aureus. This form of S. aureus is susceptible to methicillin and related antibiotics, meaning standard beta-lactam antibiotics like cloxacillin, oxacillin, and cefazolin are effective. MSSA commonly causes skin and soft tissue infections, bacteremia, endocarditis, and osteomyelitis. When the isolate is susceptible, beta-lactam antibiotics are the preferred treatment. It's important to recognize MSSA because it responds well to these first-line therapies, making management more straightforward compared to resistant strains. Let's highlight the key features of MSSA. This strain does not have methicillin resistance, which means it's still vulnerable to a wide range of antibiotics. The main takeaway is that when you identify MSSA, you can confidently use beta-lactam antibiotics. This is why accurate identification in the lab is so important. MSSA infections are common, and when treated appropriately, usually have good outcomes. Remember, not all S. aureus strains are this cooperative, so always check susceptibility results before finalizing therapy. Now let's talk about MRSA, methicillin-resistant Staphylococcus aureus. MRSA is resistant to methicillin and most beta-lactam antibiotics, making it a tougher opponent. The main mechanism behind this resistance is the presence of the mecA or mecC gene, which leads to the production of PBP2, a protein that reduces beta-lactam binding. MRSA is notorious for causing skin infections, pneumonia, bacteremia, and bone infections. Because of its resistance, treatment options shift to agents like vancomycin, linezolid, and daptomycin. It's essential to choose the right antibiotic, as some, like daptomycin, are not suitable for all infection sites. Core of MRSA's resistance lies in the mecA or mecC gene, which encodes an altered penicillin-binding protein called PBP2. This protein has a low affinity for beta-lactam antibiotics, meaning these drugs can't effectively bind and inhibit cell wall synthesis. As a result, MRSA survives despite the presence of antibiotics that would normally kill it. This mechanism is a classic example of how bacteria can adapt and evade our best treatments. Understanding this helps guide us toward alternative therapies when facing MRSA infections. Treating MRSA requires a shift from beta-lactams to other agents. Vancomycin is often the first choice, but linezolid and daptomycin are also effective. It's important to note that daptomycin should not be used for pneumonia, as it is inactivated by lung surfactant. New agents may also be considered based on susceptibility results. The key is to tailor therapy to the infection site and the patient's clinical status, always guided by antimicrobial susceptibility testing. Next, we have VRSA, vancomycin intermediate Staphylococcus aureus. This strain has reduced susceptibility to vancomycin, often due to a thickened cell wall that limits drug penetration. VRSA typically emerges after prolonged or repeated vancomycin exposure. Infections caused by VRSA are more challenging to treat, and alternative agents may be needed. Recognizing VRSA is crucial, as standard vancomycin therapy may not be effective, and treatment should be guided by susceptibility testing and specialist advice. VRSA infections are often linked to patients who have received vancomycin for extended periods. The thickened cell wall in VRSA strains acts as a barrier, making it harder for vancomycin to reach its target. This means higher doses or alternative drugs may be necessary. VRSA highlights the importance of monitoring antibiotic use and adjusting therapy based on lab results. Always consult infectious disease specialists when dealing with VRSA to ensure the best outcomes. Now let's discuss VRSA, vancomycin-resistant Staphylococcus aureus. VRSA is rare but serious, as it is resistant to vancomycin, one of our last resort antibiotics. The main mechanism involves the acquisition of the vanA gene, often from vancomycin-resistant Enterococcus, VRE, leading to a thickened cell wall and reduced vancomycin penetration. Treating VRSA requires susceptibility testing and specialist guidance, with options like linezolid or daptomycin. Strict infection control measures are essential to prevent spread. Because VRSA is resistant to vancomycin, treatment must be individualized based on susceptibility testing. Linezolid and daptomycin are potential options, but therapy should always be guided by an infectious disease specialist. Infection control is critical. VRSA can spread in healthcare settings, so isolation and rigorous hygiene are mandatory. This scenario underscores the importance of antimicrobial stewardship to prevent the emergence and spread of highly resistant organisms. Let's move to LRSA, linezolid-resistant Staphylococcus aureus. LRSA develops resistance through several mechanisms, including mutations in the 23S RNA, ribosomal protein alterations, and acquisition of the CFR gene. These changes prevent linezolid from binding to the bacterial ribosome, blocking its ability to inhibit protein synthesis. LRSA is often associated with prolonged or repeated linezolid exposure. Treatment should always be guided by antimicrobial susceptibility testing, as options are limited. Resistance in LRSA is mainly due to genetic changes, mutations in the 23S RNA or ribosomal proteins, and the presence of the CFR gene all contribute to linezolid resistance. These alterations prevent linezolid from binding to its target on the 50S ribosomal subunit, so protein synthesis is no longer inhibited. This highlights the adaptability of S. aureus and the need for ongoing surveillance and careful antibiotic use. Summarize the main treatment options for resistant S. aureus. For MRSA, vancomycin, linezolid, and daptomycin are key agents, but remember, daptomycin isn't for pneumonia. VRSA and VRSA require specialist-guided therapy, often using linezolid, daptomycin, or other newer agents, always based on susceptibility results. For LRSA, options are limited and must be tailored to the specific resistance mechanisms. The bottom line, always use antimicrobial susceptibility testing to guide therapy. As a quick reference table to help you remember the key features of each resistance pattern. MSSA is susceptible to beta-lactams, MRSA is resistant due to mecA/mecC, VRSA has reduced vancomycin susceptibility from a thickened cell wall, VRSA is vancomycin-resistant due to vanA gene acquisition, and LRSA is resistant to linezolid from ribosomal changes. This table is a handy tool for exams and clinical practice. Wrap up, remember that S. aureus resistance patterns are not always a stepwise progression. Each strain can develop resistance independently. Key points: always check susceptibility, use beta-lactams for MSSA, switch to vancomycin or alternatives for MRSA, and seek specialist advice for VRSA, VRSA, and LRSA. Infection control and antimicrobial stewardship are essential to prevent the spread of these resistant strains. Stay updated and always tailor therapy to the individual patient and infection.